Hello everyone, my name is Seung-Hyup Kim, Professor of Radiology and Urology, Seoul National University Hospital. In this session, I would like to talk how we can use Doppler ultrasound in the kidney diseases. Doppler phenomenon was first found by Austrian physicist Johann Christian Doppler in 1842, and now it became the basic component of ultrasound technique. Doppler ultrasound is an easy and non-invasive technique, and color or power Doppler ultrasound shows general changes of renal blood flow of the kidney, and spectral Doppler analysis may provide objective information of renal hemodynamic changes. There are many Doppler indexes that can be used in analyzing renal Doppler spectra, as you see in this list. But most commonly used index in renal Doppler ultrasound is resistive index, which is peak systolic velocity minus endodiastolic velocity divided by peak systolic velocity. That index well reflects the resistance of renal parenchyma against renal arterial inflow. Among other indexes, renal aortic ratio, acceleration time, and acceleration index are used in diagnosis of renal artery stenosis. Intrarenal arterial Doppler spectra are obtained from interlobar artery level. Resistive index is usually lower than 0.65 and seldom exceeds 0.7. So usually 0.7 is considered as upper normal limit of resistive index of interlobar artery of the kidney. As you see in this graph, we need to know that normal resistive index of the kidney is different according to age. It is lowest in young adults and is slightly higher in children and old adults. In addition to grayscale ultrasound findings, Doppler ultrasound, especially spectral Doppler ultrasound, may provide useful information in evaluation of various renal diseases, including renal parenchymal disease, acute renal failure, hydronephrosis, renal masses, and renal vascular diseases. Let's begin with renal parenchymal disease. Renal parenchymal disease is also called medical renal disease and usually diffuse and bilateral. If you look at grayscale ultrasound images of three different kidneys, first renal cortical echo is lower than liver echo, second same as liver echo, and the third cortical echo is higher than liver echo. This left side is clearly normal echo, this right side is clearly abnormal, but in this middle image, it is difficult to say whether cortical echo is normal or abnormal. This old but important paper well shows the difference of sensitivity, specificity, and positive predictive value when you consider cases with same echogenicity of renal cortex and liver as normal or abnormal. We consider renal cortical echo abnormal only when it is higher than liver echo, since with this criterion we may have higher specificity and higher positive predictive value. It is known that changes of renal resistive index depends on the types of pathologic changes of renal parenchyma. Resistive index is usually elevated when there are dominant tubular interstitial changes, but it usually remains normal when glomerular changes are dominant. This is a paper that showed this difference, and in their 72 biopsy-proven cases of renal parenchymal diseases, average resistive index was 0.61 in predominantly glomerular diseases and 0.76 in predominantly tubular interstitial diseases. One renal parenchymal disease where Doppler ultrasound may play an important role is diabetic nephropathy. The main pathologic findings of diabetic nephropathy are diffuse glomerulosclerosis and arteriolosclerosis that may increase renal vascular resistance as the disease progresses. It is known that the kidneys with diabetic nephropathy are enlarged in early phase of the disease, and so they may appear quite normal even when the disease is quite advanced. Here are kidneys in two different patients with diabetic nephropathy, and both kidneys look quite normal at grayscale ultrasound. But if you see these Doppler spectra, these two kidneys are very different. This left-sided kidney has normal appearance and also normal Doppler findings with normal resistive index around 0.6, while this right-sided normal-looking kidney at grayscale ultrasound shows clearly abnormal Doppler finding with markedly elevated resistive index of 1.0. This is a graph in our study, and this is a similar graph in another study showing same relation between creatinine clearance and resistive index. So spectral Doppler ultrasound will be a useful technique to evaluate the severity of diabetic nephropathy. Now let's move on to acute renal failure. Acute renal failure is another condition that spectral Doppler ultrasound may play a useful role. Changes of resistive index in acute renal failure is also type dependent, and the resistive index usually elevated in renal type acute renal failure in 90%, but only in 20% of pre-renal type acute renal failure. We may think that spectral Doppler ultrasound will be useful in monitoring the course of acute renal failure because spectral Doppler ultrasound findings reflect real-time information of renal hemodynamic status, while serum creatinine or creatinine clearance reflects the changes already occurred in the kidney, so we may expect time gap between changes of resistive index and changes of serum creatinine. We did an experimental study using a rabbit model to compare the changes of resistive index and changes of serum creatinine after inducing reversible acute renal failure by intramuscular injection of glycerol. The result was exactly what we expected, as you see in this graph. Resistive index reached its peak 12 hours after injection and returned to normal value after 7 days, while changes of serum creatinine occur later than changes of resistive index with a gap of 12 hours to 1 day. This result means that spectral Doppler ultrasound may have a very important role in real-time monitoring of course of acute renal failure, especially in this critical period. Now let's move on to hydronephrosis. There are two types of hydronephrosis, namely obstructive hydronephrosis and non-obstructive hydronephrosis, such as vesicoureteral reflux. Differentiation between obstructive and non-obstructive hydronephrosis is important. Many articles reported that resistive index is elevated in obstructive hydronephrosis but not in non-obstructive hydronephrosis, so differentiation may be possible with Doppler, but there were controversies regarding this issue. This is a 35-year-old man with left flank pain. Ultrasound shows normal right kidney, but left kidney is slightly enlarged and shows subtle dilatation of pelvocalyceal system. Spectral Doppler ultrasound on right side shows normal resistive index of 0.65, but resistive index was elevated to 0.8 in left kidney. With these ultrasound findings, including elevated resistive index of left kidney, we may say that this patient has significant obstruction on left side. CT scan of this patient shows hydronephrosis of left kidney with decreased parenchymal perfusion caused by bladder cancer. This is a 31-year-old man with right flank pain. Ultrasound shows marked hydronephrosis on right side, but spectral Doppler ultrasound shows resistive index in upper normal level 0.7. It means the obstruction will not be significant in this patient. Serial CT scan images in coronal plane in early corticomedullary phase and excretory phase show a stone in right ureter. You can see relatively well-preserved perfusion and excretion on right side. In this old patient with left flank pain, we see severe hydronephrosis with very weak flow signal without diastolic flow, so resistive index is 1.0. Coronal CT images in early corticomedullary phase and late excretory phase show a middle ureter stone causing significant obstruction with decreased perfusion and delayed excretion. This is our old study in 31 patients with obstructive uropathy, which was confirmed at intravenous urography. We compared spectral Doppler ultrasound findings with a cutoff value of 0.7 with symptom duration and first pelvocalicial opacification time at intravenous urography. In this study, spectral Doppler ultrasound had a very low sensitivity, 19.3%, in diagnosing obstructive uropathy in a whole group. But sensitivity was very high, 80%, if we limit the cases to a group with acute and severe obstruction. Here acute means symptom duration shorter than 1 week, and severe means first pelvocalicial opacification time longer than 2 hours. In this graph, this blue-colored bar indicates high resistive index value in acute and severe obstruction, symptom duration shorter than 1 week, and pelvocalicial opacification time longer than 2 hours. Resistive index values in all other groups are low. So we may say that Doppler ultrasound is not useful in differentiating obstructive and non-obstructive hydronephrosis in general, but it is useful in detecting acute and severe obstruction. I will talk on use of spectral Doppler ultrasound in evaluation of renal masses in another session, and will not talk here. Now let's move on to Doppler ultrasound in renal vascular diseases. Doppler ultrasound is very useful in diagnosis of renal artery stenosis. Renal artery stenosis is most common and important cause of curable secondary hypertension, and common causes are atherosclerosis, fibromuscular dysplasia, and Takayasu's arteritis. There are many old and new and invasive imaging techniques to detect renal artery stenosis, but Doppler ultrasound is very useful as a non-invasive imaging study. In addition to anatomical information, Doppler ultrasound can provide functional hemodynamic information. There are two Doppler techniques for renal artery stenosis evaluation. One is examining main renal artery at the site of stenosis, and the other is intrarenal artery Doppler technique. In significant renal artery stenosis, spectral Doppler in main renal artery at stenotic site shows following findings: elevated RSVP, renal peak systolic velocity to 150 to 200 cm per second, where normal value is lower than 120. RAR, renal aortic ratio, which is peak systolic velocity of renal artery divided by peak systolic velocity of aorta, is higher than 3, and spectral broadening, which means filling of a spectral window due to turbulence of blood flow at the stenotic site. Other ratios that may be used are RSR, renal segmental ratio, RIR, renal interlobar ratio, or RRR, renal ratio, etc. This is a case of renal artery stenosis at right renal artery orifice, where we see bright color due to high velocity flow through stenosis. But this Doppler ultrasound technique at main renal artery is not an easy technique. Often it is difficult to see main renal arteries because of bowel gas, and if we evaluate main renal artery only, we may miss stenosis at distal segmental artery level. In contrast, intrarenal artery Doppler is much easier than main renal artery Doppler technique. The criteria we can use with this technique is AT acceleration time, AI acceleration index, and ESP early systolic peak. Acceleration time is the time between start of the systole and peak systole, and acceleration index is the degree of systolic upslope. ESP, or early systolic peak, or early systolic compliance peak, is this small peak before a main systolic peak. This ESP is produced by compliance of vascular wall and is usually prominent in young adults. If there is a significant stenosis of main renal artery, acceleration time will be prolonged longer than 70 millisec, and acceleration index will be diminished lower than 3.0, and normal ESP will disappear. This is a normal spectral shape with sharp systolic rise with normal ESP, and as stenosis becomes more and more severe, spectral shape will become this and this. This shape of Doppler spectrum is called pulsus, tardus, and parvus, in other words, slow and weak pulse. The advantage of this intrarenal Doppler technique as compared with main renal artery Doppler technique is that it is easier with reasonably high sensitivity and specificity. And with this technique, we may detect segmental artery stenosis if it is properly done in multiple renal areas. This is a typical example of unilateral renal artery stenosis. Typical normal Doppler spectra on right kidney with normal ESP. Typical pulsus, tardus, and parvus shape on the left kidney. Severe stenosis of left renal artery at angiography. Another patient with unilateral renal artery stenosis. Pulsus, tardus, and parvus on right kidney and normal shape on left kidney. Capillary scan shows typical abnormal curve on right side, and angiography confirmed severe stenosis and stenting was done. When renal artery stenosis is bilateral, we should be careful. 18-year-old female patient. Doppler on left kidney is clearly abnormal, pulsus, tardus, and parvus shape. Doppler shape of the right kidney looks much better than left kidney, but systolic rise is not very sharp with slightly longer acceleration time, which is about 200 millisecond. Angiography shows bilateral renal artery stenosis, much severe on the left side, and this is a case of bilateral renal artery stenosis due to Takayasu arteritis. Another patient with bilateral renal artery stenosis, probably caused by atherosclerosis in an old woman. Doppler on the left side looks better than right side, but also has a stenotic lesion at angiography. This is a young woman, and the Doppler spectra from interpolar area of left kidney looks normal, but those from lower polar area looks abnormally slow and weak. Angiography clearly shows a significant stenosis of segmental artery supplying lower pole of left kidney. As you see in this case, we may detect segmental artery stenosis if it is properly done in multiple renal areas. Doppler ultrasound may be useful in follow-up of renal artery stenosis after treatment, and this is an example case. Initial Doppler ultrasound shows severe pulsus, tardus, and parvus pattern on left kidney, and angiography confirmed severe renal artery stenosis on left kidney, and balloon angioplasty was done with marked improvement. And follow-up Doppler ultrasound shows normalized spectral pattern on left kidney. Another renal vascular disease where spectral Doppler ultrasound may play an important role is nutcracker syndrome or renal vein entrapment syndrome. I will talk on this topic in a separate session. In summary, I would say that we may use Doppler ultrasound as an essential part of renal ultrasound for various renal diseases, including renal parenchymal diseases, acute renal failure, hydronephrosis, and renal vascular diseases.